I'd like to welcome Dr. Elizabeth Swisher.
Hi, thanks for having me today. I want to say thank you to Okra for inviting me to be here and for the opportunity to present. This is one of my favorite meetings of the year. It's really the advocates and the survivors that make it possible to advance research for ovarian cancer, both for treatment and for prevention. Today I'm focusing more on the prevention side, but a lot of my research also has to do with treatment, and Okra has just been really instrumental in the funding that they've provided to me as well as to many other researchers around the country and even the world. So thank you for your support. I hope you had a chance to watch the session that I did on the MAGENTA trial. But if you didn't see that live, then it's recorded and you'll have a chance to see that. I'm not going to repeat everything that I said there, but there's been a number of questions that I'm going to try to address. If you have questions while I'm talking, feel free to put them in the chat and I'll try to monitor that and answer them as I can get to them. I may not be able to get to all the questions. So here we go. So we're going to talk a bit about genetic testing, and there's a number of questions about testing patients with ovarian cancer. One of the first questions is, has the genetic testing for ovarian cancer been able to determine a common genetic connection amongst patients other than what has been associated with the BRCA genes? So the first known ovarian cancer gene was BRCA1 and was discovered by Mary Claire King, and soon after was followed by BRCA2. And those genes, many of you may have heard about, lead to a markedly increased risk of both breast and ovarian cancer. But it turns out they're not the only hereditary cancer genes for ovarian cancer. But they do account for about 3/4 of hereditary ovarian cancer. So if you take all women with ovarian cancer, about 1 out of 5 will have a hereditary predisposition as a cause for that cancer. So the other cancers, we call those sporadic, the ones that are not hereditary. Of the 1 out of 5 cancers that are hereditary, 3 out of 4 of those are going to have a BRCA1 or BRCA2 mutation. So women have inherited that mutation either from their mother or their father. But about 1 out of 4 hereditary ovarian cancers actually comes from a less common gene. Many of them are kind of cousins to BRCA1 or 2, I would call it. They have similar biologic pathways that they work in, but they have different, each one has a different risk associated with it. None of the risks are as high as you see with BRCA1 and BRCA2. So instead of, for instance, a BRCA1 gene mutation leads to about a 40% risk of ovarian cancer, whereas another less common gene, RAD51C, leads to about an 8% lifetime risk of ovarian cancer. But these risks are still quite elevated over the population risk of 1.5%. So even though for an individual, the likelihood of having a mutation in one of these genes is relatively small, they do account for enough of a fraction of the ovarian cancer that when we recommend genetic testing for ovarian cancer, we recommend testing not just for BRCA1 and BRCA2, but these other genes. And right now there's about 9 other genes that we would typically test for at the same time that lead to increased ovarian cancer risk. So one of the questions, just to follow up on that, was why don't they automatically test women for BRCA if they have ovarian cancer? Well, in fact, that should be happening. All women with invasive ovarian cancer, with an ovarian cancer, kind of the most common ovarian cancers, should have testing for hereditary risk. Even if you don't have any family history of cancer. So why is it that you could have a hereditary cancer and there's nobody else in your family that has cancer? That's because those genes can be inherited from your mother or your father. Often that gene may have been passed down from your father and he doesn't get breast cancer or ovarian cancer. Maybe people have small families or people died early for other reasons, and not everybody who has the mutation gets cancer. So you may not, but based on your family history, be aware that you have a risk until all of a sudden cancer is identified. So for that reason, if we relied on family history, we would miss about 40% of women that have hereditary ovarian cancer because they wouldn't have a marked family history. So we need to test all women with ovarian cancer, and that's been the recommendation since at least 2009 in this country, that all women are offered testing regardless of the age of their diagnosis and regardless of their family history. If you have been diagnosed with ovarian cancer and you haven't had testing, then you need to get that done because it's an important part of your care. It's possible that that somebody had ovarian cancer in your family and wasn't tested maybe longer ago or didn't get the right testing done. Then other members of the family could still be tested. If you have a first-degree relative with ovarian cancer, like a mother or a sister, even a second-degree relative with ovarian cancer, especially if it's on your father's side, like your dad's sister or your dad's mother had ovarian cancer, and you don't have any genetic testing information in the family, then you also should get genetic testing. Because the idea of genetic testing is that we don't just wait until somebody has cancer and then offer testing, that we offer testing to individuals who are at risk because of a family history or a personal history. We offer testing to people so we can really utilize that information for prevention. Most of the genetic testing in this country happens after somebody gets a cancer diagnosis. So the MAGENTA trial was a way where we were trying to actually figure out how to get testing to people in their living rooms more easily. It just happens to be that a pandemic happened when this trial finished. The trial wasn't designed for a pandemic, but it turns out that it's pretty convenient to have figured out that there is a safe and effective way to provide genetic testing to people in their house without even them having to make an appointment to come in. All the counseling is provided over the telephone. And so if you haven't seen that, you can watch that. If people have questions, I'm gonna try to avoid giving individual advice, but try to make a question a little bit more general for the whole audience. So here's a question about if you test positive for a BRCA mutation, should you get updated to see if you have any other mutations? That's a good question, it's a little bit hard to answer. I would say that we find in about 1% of patients that they can have a mutation in more than one gene. You can inherit, the genes are inherited independently, so it is possible, but the likelihood of having another mutation may not justify the cost of doing a whole nother test. So if you have a BRCA1 mutation for you personally, that explains your cancer. And it's not likely you're going to get more information by doing a more recent test. It's probably more worthwhile, actually, especially if you're dealing with a recurrence, to get the tumor sequenced for the different genes, because they include the hereditary genes, and then they also include the information that you might get that could help direct your treatment based on your specific tumor. And it'll really cover, it'll pick up if you have something else hereditary as well most of the time. So it's a little bit confusing, but probably that's more worthwhile than getting a second blood test. So can you explain the difference between genetics versus tumor testing? Oh yeah, since I just brought that up, I better explain it. So when we talk about genetic testing or hereditary testing, we're usually using a blood sample or a spit sample to get DNA. And what we're really testing for are the genes that are in all the cells of your body, which includes your cancer cells, but they're in all the cells of your body, and because they were inherited from your mother or your father. And so that genetic testing is something where we're looking for things specifically that would have explained why you got cancer, or if you don't have cancer, would explain an increased risk of cancer that you wouldn't otherwise know about. Tumor testing is when we take the sample from your cancer, usually, you know, that's been archived in pathology. So after you have a surgery or a biopsy, that tissue is not thrown away, it's kept. The requirement is that it's kept for at least a decade. And some institutions keep it longer, but it needs to be kept for at least 10 years in the hospital. So they can access that tissue and sequence it for different genes that give us sometimes an idea of different treatments to use. So the reason it's particularly confusing for BRCA1 and BRCA2 is that a germline mutation, a hereditary mutation in BRCA1 increases the risk of cancer, explains why somebody got cancer, but that mutation is also present in the cancer cells, and it specifically makes the cancer cells susceptible to some kinds of treatments. And you may have heard about PARP inhibitors. It particularly makes them sensitive to PARP inhibitors. So in that setting, the germline testing, the blood or spit testing, is also predictive of therapy. But if we had only tested the cancer in that situation, we would have still seen that BRCA mutation, and we would have still made the same therapeutic conclusion. So hereditary genes are ones that we can see in the blood and the spit and the tumor. The tumor alterations we only see in the tumor itself. So if we did a blood sample, we're not usually looking for that. Though there are more advanced ways now of trying to pick up the tumor DNA in the blood sample, so that becomes even more confusing. But the tumor testing is really more to direct therapy, and the germline testing is to understand if you're at risk for other cancers or if other people in the family might be at risk for cancer. Okay, I'm gonna read through the chat because I see a lot of questions coming up. So what organization does the tumor sequencing? So there are a number of different companies that do tumor sequencing, and I don't really want to make specific recommendations. There's also a number of cancer centers, like academic labs. For instance, I'm at the University of Washington. We do our own tumor sequencing here. And there's commercial labs that do it as well. So I would talk with your provider about that. But there's definitely some strong marketing happening because it's a moneymaker for some companies. So yeah, I guess I would have you talk to your provider about that. I heard about the microsatellite instability of a tumor increasing response to immunotherapy in a talk earlier today. Is microsatellite instability related to a specific genetic mutation? Okay, that's a really good, that's a very good question. It's much like BRCA in that it can be hereditary. Microsatellite instability is a characteristic we see in the cancer, and it does make it more susceptible to immunotherapy. It's also can be indicative of a certain hereditary syndrome that we call Lynch syndrome. So patients who have Lynch syndrome have one of, there is a mutation in one of 4 genes, and those genes are MLH1, MSH2, PMS2, and MSH6. That's kind of a word, alphabet salad. But you don't, when you have a mutation in one of those genes, it's not, ovarian cancer is not the most common cancer, but it can occur in about 8% of patients. More common in Lynch syndrome is endometrial cancer, which is uterine cancer, or colon cancer. But it sometimes can also be ovarian cancer. So microsatellite instability could be suggestive of Lynch syndrome and a hereditary mutation, but you can also see microsatellite instability that is occurring only in the cancer and isn't related to any inherited mutation. So when they do the tumor sequencing, and there's some other tests that can be done to determine if it's hereditary or non-hereditary microsatellite instability. Either way, it has the same prediction for whether or not immunotherapy is a good choice, but figuring out whether it's a hereditary thing is important for you and your family in terms of other health recommendations. Yeah, so if you've been diagnosed with multiple cancers, you should definitely have genetic testing. And ovarian cancer itself is an indication for testing, as I mentioned. But if you also have had a second or different cancer, that just that just makes it more likely. Usually the testing, if you've been tested once and then you get tested with another cancer, and then you get diagnosed with another cancer, usually the testing we've done is pretty comprehensive for almost all cancer genes or cancer susceptibility genes. But you should meet, you should meet with a genetic counselor and kind of go over your new diagnosis to determine if it changes, if you had adequate testing for that already. So somebody wants to know about HRD testing. So yeah, there's whole papers written on that. So I work in that area a lot. So HRD is a defect in DNA repair. So all your cells have ways of repairing DNA mistakes that happen when the cells replicate. So when the cells replicate, they have to double their DNA, and when they copy their own DNA, sometimes mistakes are made. So it's really important for cells to survive to have the right accurate reading of the DNA. So there's very important mechanisms in the cell that repair any defects in DNA, and they can also be used fix defects in DNA that occur because of things like ultraviolet light that damages DNA, or other kinds of carcinogens that damage DNA. But anyway, these mechanisms for DNA repair are very important. So one of the most important mechanisms is called homologous recombination, which is HR. So HRD stands for homologous recombination deficiency, and that is a defect in DNA repair that's specifically associated with having a BRCA mutation in the cancer. So a BRCA mutated cancer will have HRD, but some other ovarian cancers will also have HRD because it's just a pathway that's often defective in ovarian cancer. And that is a predictor for people who will respond to PARP inhibitors. It doesn't guarantee you that you'll respond to a PARP inhibitor if your cancer has HRD, but if your cancer doesn't have HRD in it, then it's much less likely that you would respond. So it's really a test that's done to help us figure out the utility of using a PARP inhibitor. And it may or may not be associated with a hereditary defect. Okay, so this is a great question. I think the scientific community is trying to answer it. Does the tumor testing result from the original surgery biopsy have the same results as a biopsy from a future metastatic distant lymph node? So one of the questions is really, do you have to have a new biopsy to do this tumor sequencing, or can you just access an old sample from your original surgery? And that's probably different for different kinds of cancers. But specifically for ovarian cancer, we've done studies where we looked at tumor sequencing in the original diagnosis and then later in the pretreatment biopsy. And there's rarely any differences in predicting in the things that predict response to therapy. So some differences may arise, but they're not usually the ones that have any impact on our treatment decisions. That's kind of based on what we know right now and the way that we're treating the cancers right now. It could be that we develop a new treatment for which there's an alteration that we really need to know from a sample, like right before we use that treatment. But for the treatments that we're deciding right now for ovarian cancer, it's perfectly fine to use an old biopsy specimen. And it's going to be in agreement with a newer specimen or a metastatic specimen from a different location. But as treatment changes, our recommendations on that may change as well. So let's see. You guys have a lot of good questions. You're stretching my brain. So have there been any advances in 2020, breakthroughs in sequencing that could specifically target certain treatments for an individual's ovarian cancer that's already surgically removed? Well, we're really working, so I think this comes back to the HRD question. The PARP inhibitors have moved into frontline therapy. So if somebody's cancer is removed surgically and they get chemotherapy, then they're now approved. The PARP inhibitors are approved, at least a couple of them are, to be used in the frontline setting as opposed to if somebody recurs after you finish your chemotherapy, in order, what we call maintenance, to go on those drugs for 2 or 3 years, so a long period of time. They're oral though, and you go on that to diminish the chance of the cancer coming back. What's happened this year, so one of those approvals happened this year, so I'd say that was an advance. And in terms of predicting who would respond, the HRD testing is being utilized to try to figure out, because nobody wants to finish their chemo and go on a drug that makes them nauseated or makes them feel tired. It costs about $10,000 a month for 3 years if it's not providing you benefit, right? Like, you'd rather be off treatment than on treatment and fatigued from the drug if it wasn't going to provide you benefit. If the cancer was going to come back anyway, then you'd rather spend that time off treatment. If you're going to keep the cancer from coming back, then it's worth tolerating some side effects. So the more that we can figure out who are the people that really get the benefit, the more we can help you individualize the decision making about whether that's a good choice for you or not. We don't want you to have the toxicity if you don't get the benefit. So there's really a lot of work in this HRD testing. It's really not just one test. There's one test that's available now, but nobody thinks it's the best test. So your physician may not order it because it's not necessarily the best test. Or your physician may say, well, it's the best information we have now, so I'm going to order it. So I think there's a lot of disagreement in this country about whether or not this HRD test is worth getting in order to decide on treatment. And so a lot of work that I'm doing, and work that got started even with OKRA some years ago in this area, is on trying to develop better predictors. But none of those are all in development, and none of those are really ready for prime time and ordering right now. But we're definitely working on it, and a lot of research efforts are going in that direction. I have about 5 more minutes, and I definitely have more questions here. Is there any difference in survivability for women who test positive for HER2? So HER2 is a gene, it's not hereditary, it's in the cancer cells, and it predicts response to some drugs that specifically target HER2. Herceptin is a drug that you may have heard about that's used frequently in breast cancer. In ovarian cancer, it's very rare for there to be amplification of HER2. It's more common in a cancer type called uterine serous cancer. If there is amplification, meaning an increased number of copies of this gene in the cancer, then we do like to use these drugs that target this specific pathway. It's definitely quite rare in ovarian cancer, and a little bit more common in uterine serous cancers. I'm just making sure. I like to do the live ones. They're kind of fun. I know there's really good questions that have been sent ahead of time as well. So so if you have a BRCA mutation, one question is, are they still recommending a preventive mastectomy, or what is the new news? So I would say that mastectomy for prevention of breast cancer for women that have BRCA mutations is still an excellent option for patients. But we always hesitate to use the word recommend, because in the setting of breast cancer prevention, we have more options than we do for ovarian cancer prevention because there's much more effective screening. So some women choose preventative mastectomy, and we would certainly support that decision. But other women are choosing to do more intensive surveillance, usually with breast MRI, usually combined with mammography, but definitely including breast MRI as a more sensitive method. But remember that early detection is not prevention. And so it means that we'll identify if somebody gets breast cancer, we'll identify it early. lymph nodes would be negative, but that person will probably have a mastectomy at that point, may need chemotherapy, and may need radiation or other interventions. So early detection can help, saves lives, and that's really, really important. But it's not actually prevention. So if you really wanted to avoid going down that whole pathway at all, then a preventative mastectomy does remain our most effective option. But it is an option. Yeah, so kind of the same question, one of the similar questions, which is like, if your cancer comes back 5 years later, should you have that cancer retested again? And if the majority of the time in ovarian cancer, if we're talking about tumor sequencing, the answer would be no, if it's been done that one time. But 5 years ago, we really weren't doing that much tumor sequencing. So it's, I would find out exactly what your cancer was tested for 5 years ago before you make a definitive, before you just assume that it's been done in a way that it would be done today. So your oncologist should be able to help you make that, find out what you were tested for, and are there things that you should be tested for now that you weren't tested for then? Because certainly things in 5 years have changed a lot. So one of the questions is, should my daughter be tested for BRCA if I'm negative? And should my children be tested if both of their parents have had cancer? So if you are an ovarian cancer survivor and you test negative, then your children don't need to be tested for the same thing, because they're not going to inherit. They can't skip a generation. So it means we don't have an explanation for your ovarian cancer. It's probably not hereditary and doesn't impact your daughter's risk. On the other hand, they can get risk from their father's side. So if both their parents have had cancer, genetic testing may be indicated for them, but that kind of depends on what cancer it is. So that's where it's really important to know your history, know your family history, encourage your daughter to know her history. The things that are important to know are what cancer, who had cancer, what's the relationship to them, and what age was that cancer, and where did it start? So where it started matters, not where it ended. So a lot of times people, think somebody had a brain tumor, but really the cancer went to their brain at the end of their life. Really, we want to know where it started, because that helps us know what kind of cancer it was and whether it's likely to be hereditary or not. So if you gather that information in your family, then you can take that information to your physician and find out. There's also, we just started a ovarian cancer awareness campaign for genetic awareness of ovarian cancer called Any Mountain, and we have an app that you can go to and put your family history in, and if you meet certain criteria, it'll recommend genetic testing for you. So there are, if you get turned down by your physician and you're still worried about your family history, there are other resources you can utilize to try to assess your risk and see if genetic testing makes sense. I think we're getting really close to the end here. So would you talk about the importance of high-risk screening for women with these histories? Yeah, so for women who have a known genetic mutation, we personalize a prevention plan and a screening plan for them based on what gene is it, so what risk does that confer, because each gene is different. How old are they? What are their priorities? We really want to make a personalized prevention plan. So when somebody is 25, they don't really have a ovarian cancer risk at that time. But if they have a BRCA mutation, it's time to start doing breast cancer surveillance. But we don't, I basically tell them, you're not at risk for ovarian cancer now, just focus on starting your breast cancer screening, and of course, don't text and drive. So, which is probably a higher risk for them at that point. On the other hand, if somebody's 45, that's very different. Now they're at an age of risk, and we really have to think about it. So I can't really give you specific, do this or do that, because it really needs to be personalized to the risk of whatever the specific test result is, as well as your age and your personal history. Also, if you have somebody who's been just diagnosed with ovarian cancer, for instance, I recommend, and they have a BRCA1 mutation, I don't think they should have a preventive mastectomy at that point. They should, what they need to do is prioritize treatment of their ovarian cancer, and get through that first. And they can consider a mastectomy down the road if usually I want to see that they're at least 3 years out from their mastectomy, so that they could be completely adequately treated for their ovarian cancer before they would consider a mastectomy. So I think I'm basically running out of time. Elizabeth, did you guys, we were supposed to stop at 5 p.m. Eastern?
Yes, but feel free to take a few more if you want. It's completely up to you.
Okay, I have a couple more in the chat, so I just keep going for a couple more minutes.
Thank you.
What is the name of the app? So we just launched this last night. It's called Any Mountain, and it's a web-based app. So if anybody, I can send it to Elizabeth, the link to it, and then people, we've been working on it for a year, but it just went live last night. So I can definitely send it to Elizabeth and she can pass that on to the group. We want to raise awareness. So even if you're not interested in using that app, and if you can share on Facebook or social media or with your friends, we want to create a mountain of interest and understanding risk so that people can get genetic testing before they get cancer. So I'm guessing that a number of you are survivors, and I know that all of you would have wanted the opportunity to avoid getting cancer if at all possible. And many people get genetic testing for their family as much as for themselves. So we want to really spread that word. So thank you for that. I will get that to Elizabeth. I think I got most of them. Elizabeth, do you see anything that I'm, let's see. Yeah, I think I hit most of them. So again, I just really want to say thank you to Okra for their, and all of you for your interest and for supporting Okra, which does such important work in our community. Really just life-saving work that I'm really grateful for. So thank you guys all for your interest. If you didn't see my presentation on the MAGENTA trial, that was sponsored by Okra as well as the National Ovarian Cancer Coalition. We think it's going to change the way we deliver genetic testing for women.